Good morning, everybody. It is nice and early here on the West Coast, and it is absolutely my pleasure to be with you. And particularly, it's a pleasure to be with my wonderful friend, Dr. Joel Fein, who is just so phenomenal. And it's just an absolute joy to have an opportunity to present next to such a wonderful human. So, we're going to speak with you a little bit about violence prevention on the front lines, caring clinicians coast to coast. And the really exciting thing about this is that you're interested because about 15 years ago, when Dr. Fine and I were just getting started, 20 years ago, even, the level of interest amongst people who worked in the hospital was not all that high. And now I would say not only is it burgeoning, but it's skyrocketing. And we're just thrilled to see this. So, we're going to talk to you a little bit about how we got through this journey thus far. We are going to cover, as you see there, who we are and what we're doing here. It really takes a certain kind of a wake up moment, I think, to be in a position like this where you generate interest in hospital based violence intervention program. And Dr. Fine and I will share with you a little bit about our journey. And then the birth of our network, the hospital based violence intervention programs have a network now called the HAVI, and we'll go through that with you. And what HVIPs have in common, there are a lot of ways to approach community violence prevention. So we'll define what we are and what we're not really. And then to go through what could go wrong, because a lot can. And we want to save you the heartache along the way of some of the barriers and pitfalls that we've experienced and how to get it right. And finally, how do we know it's working? Dr. Fine and I have had an opportunity to work with some amazing individuals to be able to evaluate programs like this. And as mentioned, Dr. Fine is currently the research chair of the Health Alliance for Violence Intervention. So we'll go through a little bit of that. So, what are we doing here? And if you go to the next slide, I'll tell you a little bit about why I'm here. So, I'm a trauma surgeon, and I encountered a young man when I was just an intern in surgery. His name was Michael, and he was 16 years old. And sometimes you feel like, as an intern, really all you're doing is writing Tylenol orders. But I had an opportunity to get to know Michael quite well a million years ago when I was an intern. And what struck me about him, this 16-year-old who had been shot, uh, was our conversation around what he may do when he grows up. And what Michael told me was that he didn't really have those aspirations. He didn't have those dreams because he just felt like he might not live to see 25 years old. And as someone who grew up in the suburbs and made the assumption that I was going to go to college and do something useful and have a future, it was really powerful for me to hear Michael speak like this. And 2 weeks later, Michael was shot again and brought back to San Francisco General Hospital. And I wish I could reach out to him today because it put my career on its head. And so along the way, I developed a sense that I needed to do more than just to respond to traumas and take people to the operating room and put really, really fancy bandages on injuries. But I needed to actually understand how to heal and how to go upstream. And that's what motivated us to move forward. And lessons from Harbor Road, where Michael came from, stuck with me, along with an understanding that I absolutely didn't have the level of cultural humility that it took to be able to enact programs that were more comprehensive. And then finally, that understanding led me to know I absolutely needed to work hand in community and to engage leaders in the city at that time of San Francisco who first funded Wraparound in San Francisco based on the fact that we had seen him on the news, on the nightly news, saying, I don't want to be reelected unless I can get the homicide rate down in San Francisco. So we made an appointment and we told him how we thought he might be able to do that. And he funded Wraparound. So next slide, I'll just take a quick mention before turning it over to Joel. As you can see from this painting of one of my patients who was shot in the shoulder and had a brachial plexus injury, this is somebody who didn't just experience injury, but if you look at this painting, you know he's experiencing trauma. So just for me to try to take care of his injury alone never just seemed enough until we came together as a Javi family and we could really think about how to heal. and how to help send people on a different pathway so that they could not just stay alive in our trauma centers, but to thrive. And this young man, amazingly, was right-handed, and he learned how to paint from one of our volunteers with his left hand and did this phenomenal painting. So with that, I'll turn it over to Dr. Fein.
Thanks, Rochelle. And Rochelle, we have this mutual admiration society. We did come to this similar times in our careers. The reason I'm here is because of some of the work that Rochelle and others have done. I trained in pediatrics and then a fellowship in pediatric emergency medicine. Somehow a grant opportunity came up from the William Penn Foundation to start hospital-based violence intervention. And I was thinking, as I was going through, the same way that Rochelle is, we're doing this treat and street all the time, and we're not necessarily addressing this issue. But yet I had no idea how to do a violence intervention program. And my colleague, Betsy Datner, who's at Einstein now, was at HUP, and we basically designed a program on paper. We had community volunteers, they had no training, they had no support. It was the late 90s and violence was rampant in Philadelphia, and we were really struggling. That lasted for quite a while. We had 2 grant funded projects over that time. And then I had the opportunity to run a CDC Academic Center of Excellence on violence prevention. And in that grant, they required us not to have hospital-based programs. It was all community-based programs, which was a really good experience from a learning perspective to do community-based participatory research. But we couldn't fund the hospital-based program that we wanted. So when that ended, I was able to put more focus in 2012 on a new program at CHOP, having garnered the lessons from the first program and also all of those lessons that Rochelle and people who have been doing this for years, like my friends at Healing Hurt People. And so we were able to actually create a program that would sustain and be a little bit more successful. Along the way, you'll see that this is kind of a family that we're in, because everybody in this is doing it because they've seen too much and they want to stop it. For those of you who are starting a program at Crozier and in the community of Chester, we know, Rochelle and I and everyone else who's done this knows what it's like to try and formulate a program. And it's really important to start with what you have. And what you have in the Chester Community Coalition and the hospital is a wonderful partnership that can develop if people are listening to each other. And that's going to be something that I think you're going to treasure. What I've learned, and both of us have learned, is that if you have a small success, you then start to get buy-in. People are a little bit hesitant to get in at the ground floor unless they know that this can be successful. And most of the hospital-based violence intervention programs that exist actually exist because they've gotten hospital and community buy-in, but it wasn't always as easy as that. And so we've come a long way, baby, for the hospital-based violence intervention programs. And we're going to describe a little bit about the network that we are part of that we keep calling The Hobby. And the reason we're calling it The Hobby, by the way, is because the website we could get is thehobby.org and not hobby.org. So we're just going to keep referring to it as The Hobby. It's not an odd thing for us to say. So that network started out in the late 90s, as we said, and it was mostly a group of really 7 or 8 programs in the 1990s. Milwaukee Children's and Oakland, Caught in the Crossfire in Oakland, was one of the first 2 programs to start putting this out. And that's what I think Rochelle and I got excited about, was that there were other people who had the same idea and were doing it somewhat similarly to us when we were working in this field. Quickly, Boston, Philadelphia, San Francisco, Baltimore, Chicago all followed. And in 2009, Caught in the Crossfire, or Youth Alive, the group who, the larger organization, held a conference out in Oakland, California. That was the first national symposium, and it was really only 8 programs at the time. And there was some early interest from funders, such as Kaiser Permanente and OVC and California Wellness, that helped that conference occur. And we'll be showing you some pictures from those early days as well. The amount of emotion that people had when they joined together and realized that we're all in this and we're learning lessons together. And imagine finding out that you're doing something as your life work, and then all of a sudden you find all these other people that are in the same sandbox. It really was like a family. And this is a picture of Marla Becker, who was at Youth Alive, Caught in the Crossfire at the time with Dean Calhoun. We have now a Marla Becker Award. Marla's still out in California working in this area, that is given to 1 program a year to give them free registration to a conference and support from the hobby. We also realized that what we're learning could be disseminated and created a what we call best practice guide to violence prevention, which is old now. It's actually started in the late 2009 2010 area, and probably needs revision based on some of the things we've learned in the past decade. But it is available on the Office of Victims of Crime website, and I know Fran Steyer and others have taken a look at this as well. We were called the National Network for Hospital-Based Violence Intervention Programs, and we blame Marla Becker for that name. But it is a long name, but it's very descriptive. And it was initially headquartered, as we saw, in Oakland, California. And then our colleagues at Healing Hurt People, Ted Corbin and John Rich and Linda Rich, and I, Chop, were able to start to take over some of the important headquarter work. But that was challenging. We were all using institutional in-kind support to do that. We didn't have any real funding to be the headquarters, and we were growing, as you can see. In 2009, 2010, there was a kind of quantum leap of even another 10 or 12 programs, and so we then were able to transfer back to Oakland with some funding that was obtained through federal funding, and then even more in the past few years. The support for this kind of work has really increased, and people like Fatima Dreyer were able to get even more funding through our campaigns. We actually established a fundraising campaign to hire an executive director, and Rochelle was one of the brainchilds behind that, along with Ann Marks from Youth Alive. And that executive director, who I just named, Fatima Dreyer, has really changed the trajectory of us, and we've got now a significant amount of funding to create a staff for our national network. And we've got a lot of work groups that are also staffed through the hobby. As you can tell from the map, this is why we're calling this talk Caring Clinicians from Coast to Coast, because we really do span the entire nation now. You can see there are a dearth of programs sometimes in the South, which we're now working on to try and promote. And there's probably about 40 more programs in the country that have been contacting the hobby in order to become full-fledged programs in the country. Anything to add there, Rochelle?
No, I would say, and we'll go into this a little bit more, but I would say you're spot on with the development of other programs right now. And we're even having a targeted approach towards trauma directors at the American College of Surgeons in regions that we know have a dearth of programs. So it's exciting to have high-level partnerships in our societies who are helping us with the campaign to get hospital-based violence intervention programs in places that don't exist right now.
And so this is a part of our talk where we feel like we could take some questions. Sherry will read them out to us, and Rochelle and I will try to answer them as best as possible.
Yes, there are a couple of questions that are now in the chat, and feel free to write more as I'm speaking. One of the questions is, how did you come up with training materials for the outreach and community workers? Who did that? You are coming from a medical model, a hospital-based model, and this is somewhat of a different nature. So how did that happen?
Rochelle, you want to take that? Actually, there is a 40-hour training that exists right now. So do you want to take that, or should I?
Keep going, and I'll talk a little bit about the inception of it. But if you want to talk about how it stands right now, Joel, that's great.
Sure. So what's really interesting is that there are some, and Rochelle will talk about this later in the talk, there are some exciting developments in policy that have allowed us to, in some states, in particular, think about billing for the work that our outreach and what we call our violence prevention specialists do. And as a consequence, we had to develop this training, which is a 40-hour training for them. And it was a group of people and actually spurred on through the California groups that had mostly done this work. And I know that Ted Corbin and John Rich and others in Philadelphia were involved in developing that training. But it was really out of experience. And it was done through because we had primary workers, frontline workers that we have been working with for years, and they actually participated in the development of the training. So it was really kind of an experiential approach to it with some theoretical models behind it. And Rochelle, I'm going to talk about literally the inception of that and how it grew.
I would really focus on something that Joel said, and that is that the violence prevention professionals, it's their model, and the people that we chose for this program to be our partners are coming from a very different method and a different model than the medical model. What we realized early on was that social care absolutely needed to be integrated into medical care, into trauma care, into pediatric emergency medicine care. And so we were not the ones who were doing the training. And what was really cool about this was that we were hiring people from communities with cultural humility who had a wealth of experience in different arenas in social care. And we had this really great exchange, even across the countries where we were learning from one another, like Joel had said, and built our training on that experience and that exchange and understanding, just like we're going to talk a little bit about this here, of the barriers and the pitfalls as well, so that we could learn from each other's mistakes and from each other's triumphs.
Well, thank you. I have one more question, and this is from Alexia Clark, who is a community clinicians who's involved in the Chester Community Coalition. What helped create buy-in with the hospital staff and community partners for your new programs?
Yeah, I think we're going to go into this a little bit
Okay.
in the next phase, Alexia. So thanks for the question. Hi, Alexia. Good to hear from you. And so I think I'm going to restate the thing I already mentioned, which is the small successes are going to be the ones that grow. And what we'll talk about in the next phase is figuring out what's important to the stakeholders and making sure that if it fits into the model that you think is the right thing to do, you focus on that when you're presenting it to them and when you're talking to them about it. So, if the hospital wants public relations around something, that's something that they're interested in. They want community benefit. We'll talk a little bit about that. So, that's kind of foreshadowing a little bit next section of our talk.
Okay.
It's really important to discuss what we have in common and what sort of area is our area of expertise at the Javi and amongst our hospital-based violence intervention programs. And the reason for that is just around training and technical assistance, or it's around the type of research that we do. It's really important to define ourselves so that we have this expectation of what we can provide for fledgling programs and what we can't. So what we have in common in our elements is this notion of engaging people when they're in the healthcare system. As I mentioned, it obviously didn't feel right, and it's not right just to provide the capacity to take care of injuries, of physical injuries, but how do we actually heal the people that come and seek our help after they've been injured? It is in some ways a great opportunity as people are healing from their physical injury to have with you hand in hand as physicians, to have with us somebody from the community who is the ultimate of cultural humility, who gets it on a level that I cannot. To be able to go to the bedside of someone who is getting through a violent injury is absolutely essential. And at that time, we also in our hospital-based violence intervention programs have this violence prevention professional do an assessment, a psychosocial assessment, safety goals, needs assessments. And that sort of scaffolding holds true in pediatric centers and it holds true in adult centers. And then really the crux of this is this long-term case management or post-discharge case management. So 3 to 6 months. I just heard from somebody in San Francisco who had gone through wraparound 12 years ago. He's a chef at one of the local restaurants and was excited to get to go back to work post COVID. But this sense of not just case management, but really mentorship over the course of the time that people are enrolled in the program is really key. The frontline workers, our violence prevention professionals, not only know the neighborhoods and the resources, but they know how to get there and they know how to make people stay safe. So not taking the 9 bus, but rather taking the 33 bus to do tattoo removal. These are important nuances that keep people safe and keep people on target for goals to really start to address the needs. Relationships with community organizers and agencies isn't just a good idea. The program will fail without it, without working hand in hand and understanding that it takes a really, really quiet spirit to listen to our communities, as Joel had said, to understand what was needed is absolutely essential. And trauma informed care in a more substantive way is actually coming to a trauma center near you. Right now, the Committee on Trauma is actually developing a course, a curriculum. But people who are coming in as our violence prevention professionals, they are the course, they are the study section, they are trauma informed. And so to learn side by side, I can't tell you how many of us have gained a whole education around social care watching our partners in this work. And all of this is really rooted in racial and social equity. Finally, we're saying out loud things like structural racism that have existed for hundreds of years in our country. And to be able to address it as a root cause, really at the level of our communities, at the level of our hospitals, in addressing social determinants of health, which we'll talk about later, really is critical and is a common element in our hospital-based programs in the hobby.
And Rochelle, I'm just going to point out there is not a typo, although you might have thought it was. The teachable moment can sometimes be the teachable month, and it's because some of the clients are not ready to talk the first time or second time we visit them, but it is they have to be you have to be in the same place, in the right place to do this. So recruitment does happen within the first few weeks after an injury, but maybe not right on the day 2 or day 3. That's why I changed that from teachable moment.
I love that. Yeah, last night I emailed Joel and I said, I think there's a typo in slide number 16. So nope, I'll explain it. So thank you for that, Joel. To carry this forward more, so hospital-based violence intervention programs at their crux, the backbone is our violence prevention professionals. But why do we address the social determinants of health? Simply because that is such a huge impact of our overall wellness or lack thereof. So if you see, like in this slide, very clearly socioeconomic factors contribute 40%, and physical environment, even green spaces or lack thereof, contribute another 10% to our overall drivers of health outcomes. So really very critical for us to address this if we're going to provide whole person care. Anything else to add to that, Joel, perhaps from
No, I really like this slide, and I think that it's something that we're teaching now in medical school, but you and I did not learn that in medical school. It was all medical, and just do the right thing. And this is the plate, right? You think about when you have too much on your plate and you're not necessarily able to handle some of the social or socioeconomic or other issues as a clinician. And I always tell people, this is not more on your plate. This is the plate.
That's right. Well said. And so a little bit about what we have recognized over the years, and Joel and I have had many conversations about injury recidivism. And that was the early marker, and we'll go into it a little bit more later, but that was the early marker of, quote, success of these programs. But we've learned a lot over the years in that it can't just be about recidivism, because we can't change the ecology in our urban centers overnight. But what we can do is one person at a time build social capital. And how can we recognize building that social capital and understanding the value of our programs? And that is really through the eyes of our clients. So this is a slide just showing the violence prevention professionals' relationship and perception through the eyes of the client. So we conducted semi-structured interviews and found several themes that emerged from these discussions of our clients at Wraparound. One of which was that case managers understood and could relate to clients' socioeconomic context, like we just mentioned. And like theme 6, how the case managers engendered mutual respect and pride in clients. Like one of my dear friends, violence prevention professional in San Francisco, always says, I believe in them before they believe in themselves. And it's so critical to have that role model to be able to engender such empowerment and belief in somebody. It's really key. We've done cost analyses looking at recidivism and Markov analysis in health economics to demonstrate the cost effectiveness of hospital-based violence intervention programs. Yes, they cost money, but it costs a whole heck of a lot more to be putting these really, really expensive Band-Aids on people and caring for them in the ICUs for upwards of weeks at a time sometimes. Anything to add to that, Joel?
It's the same thing we've been hearing for so many years, and cost effectiveness studies are actually quite difficult to do. And so Rochelle has done a number of two, in particularly Sentinel works on that, and we have a couple from Philadelphia. But in general, we know it's just intuitive that ICU care and post, lifetime of care is certainly, if you're talking to bean counters who only want to think about, which very rarely is that the case, but if they only want to think about the money, it's there as well.
And so a little bit about what we are not. One of the biggest reasons why this is important is for people in the community who start to get to know the program, understand what we can do and what we can't do. There was a misunderstanding in San Francisco that the Wraparound Project saw people and who were injured and their siblings were also enrolled in the program. And so we got a nastygram from a local journalist claiming that we were not seeing all the people who we were supposed to see. And we were a tiny little program at the time and couldn't take all in who was at risk for violent injury. We could only take it at that time people who had been violently injured. So it's important to define what you can do. And what our Javi network programs are not, we're not street mediation or violence interruption. Violence intervention and interruption get minced a lot of times. For us, intervention is that long-term case management, looking at the social determinants of health and risk reduction resources in the community. We often in cities work hand in hand across that spectrum with partners in Cure Violence, for example, who do more of the violence intervention. But it gets really confusing because some Cure Violence programs have hospital-based programs. So it's just think about it in terms of that spectrum of preventive care. Some of it's interruption and some of it's long-term intervention. We're not child abuse or intimate partner violence practitioners. Of course, this is an issue, and the way we address it is to go to those who have that expertise in our hospitals. We work oftentimes hand in hand with trauma recovery centers, which provide a lot of context here on the West Coast, a lot of domestic violence care and case management that might be longer term. The focus is on mental health recovery. Wraparound actually has a contract with our local trauma recovery center to provide the mental health resources. They have an office right in the Wraparound offices. We're not strictly research programs. We know to keep the wheels turning and to be true to ourselves, we need to evaluate our programs. Dr. Fein has a wealth of experience in doing this and even setting us up to understand what the variables should be that we measure. But we're not just in and of itself a tried and true blue research program that is not associated with the need for evaluation.
Yeah, so I just pulled this picture off the internet, but it is what can go wrong. Sometimes we feel like this, and how can it go right? And you're going to hear from two of my favorite people, Jackie and Jody, and the next about the CHOP program. And we struggle with every day with the work that we do, and we know what can go wrong because we experience it. But we also know very much what can go right. And I think that the issues are really I'm going to talk more in terms of program development rather than in terms of actually running the program, because I know that Jackie and Jody will be more interested, you'll be more interested in hearing it from them because they're doing it on the front lines. The most important thing I can say is that is the second line, which is the community. What does the community need? Right? What is it? And we, of course, as hospitals, especially nonprofit hospitals, do community needs assessments, and violence is always on there, mental health is always on there. But really listening to whoever is representing the community, and that's not always the people that say they're representing the community, so you kind of have to figure out who it is, and that sometimes takes important conversations to have, and you have to use your spidey sense sometimes to see if someone is, or some group is putting themselves out, saying they're doing but they're not doing it. Rochelle and I both mentioned starting out small and not being able to necessarily take everyone into the program that you can. And we were randomizing, and we may still continue to do that if we have too many clients that we cannot see, because you want to do the right thing for as many people as possible, but you can't stress your team to the point where you are unable to take care of anybody and they're not able to take care of themselves. I think that SWOT analysis, that's everyone kind of is familiar with the kind of term of looking at what can threaten and what are the opportunities that you can have, strengths, weaknesses, opportunities, and threats. Understanding both the external and internal politics, really what I call doing kind of socializing an idea with your hospital and socializing it with the community members that are involved, with the community groups that are involved, and really having conversations about it before just saying, okay, I've got a grant, I've got to write it in 5 weeks, and please just join me and say you'll join me and we'll work it out later. You will not work it out later unless you start talking about it now. And so thinking about who are the welcome partners, who are doing stuff in the community already that could be partners, as well as may view this as competition. And you don't want to set up a competitive nature. You want to join with people in the good work that's being done in the community already, because you aren't the first person there and you're not going to be the last person there in setting up a program, and you're not going to be the last hospital that tries to do this. I always say, think about a 5-year plan for foundational funding. Foundation meaning not coming from a foundation, although that's nice, but just a 1 or 2 year plan is going to be very difficult to implement. There's a long startup period for these, and you need to make sure that people who are working with you have job security. And that job security is not, well, we can hire you for a year and let's see what happens. That's not where you're going to be able to find the best people. So I think it's aspirational. It's not always possible, but it's really, I think, thinking about the 5-year plan. And then most importantly, the mental health of the people who are not only in the program, but working in the program is key. And we can't forget that. This is to overwhelm you, this slide, because it's an overwhelming slide. And I'm going to let Rochelle take this, but it basically is a slide that, and I'm sure we can send the slides to you guys to have this as a resource. But it's really, Rochelle says she has this on her wall, and I think it probably replaced Justin Bieber at some point on that wall.
Telling my secrets, Joel. Jeez.
So go ahead, Rochelle. Talk through this one.
What more is there to say? No, it was actually that guy from Wham. What was his name? That was the one that was on my wall for a while. Anyway, so this is not meant to pop out at you that you have to do all of this at once. But that said, you have to get to it all at some point early on. And so certainly there's blood, sweat, and tears on my paper copy of this. But the reason that it's so important to hold it up, and if you just look at the purple words there, you can see all the critical elements that make a program feasible. We already touched on a lot of these things, but injecting in this also is the way we go about our messaging to each of our stakeholders. It's so important to be able to, in the situation of San Francisco, go to community-based organizations and sit in the back of the room and be quiet for several months at a time, and understand exactly how your program is going to fit and how to access a referral network. And those are things that take being quiet if you're coming from it from the vantage point of a trauma surgeon or a pediatric emergency medicine physician. And then to start to have those dialogues that are so critical. But also knowing how to approach people like your organizational climate, your hospital, as Joel had mentioned. I've had CEOs of hospitals, one in particular in California, say, why would I want to do this if trauma is my cash cow? And clearly this particular CEO was not getting the message as to how important it was to do a community needs assessment and to serve the community in a more holistic way. So, you start hearing and seeing it all if you're in this for a little while, and understanding how to message things to your stakeholder is really quite critical. And that goes along not only in starting up, but in sustaining a program.
And I think the message that just to reiterate one thing that Rochelle said, staying in the back of the room is important, and listening. It's also really important to stay at the table. Even through the hard conversations, people will, especially this from community-based research, not necessarily saying, well, okay, this looks like it's not going to work out for me, and therefore it will not, I'm going to leave. That's not going to work. You have to be at the table through the hard times and make it work over time. Some of those meetings are very, very difficult.
Yeah, that's an excellent point, Joel. And I think it's really important also, which goes along with that, what you said about providing job security for very, very tangible, real reasons we have at the Ivory Tower or at the hospital let down our communities that we serve. And there's a long history of that in medicine, of course. So we're hiring violence prevention professionals from the community. We have to make a true commitment to them that will take care of them as our own and make sure that they understand just exactly how essential the work is that they're doing. That they're just as important on rounds as any of the rest of us. And really buying into that over a 5-year plan, like Joel had said, is really important.
So we've gone over a number of these, but I want to concentrate on a little bit of what happens when you're expanding, right? So the work gets supported, it's starting to work. There's hard times and good times, and one of the things that I've learned and we've all learned as a group is you got to find the right people to do this job, and staffing is not that easy to do because these are very, very difficult jobs to do, and they're not paid as well as other jobs that people may take. So they're doing it for a passionate reason, right? So those people that have the passion and stay in it could be doing other jobs that are a lot easier. So it's really important to take that time, providing the good, positive stories back to medical staff and hospital administrators are really important to them, and to anything when you're starting any program, giving that positive feedback to them for referring people and telling them what happened with their clients or their patients is good. We one of the questions we used to ask on our applications for what was NNHVIP, now the hobby, was, do you have clinical meetings? Because it's really important not to have just one person out there doing work and not being able to run by problems and issues with a larger team. And you'll hear from in the next talk about like what our team consists of, which was expanded to include adolescent medicine and psychiatry and psychologists and others. But even just in a smaller group, just having a few people talking around cases is really important. Case management is a team effort. It is not a singular effort. And then finally, tracking what you're doing will become much more important if it'll become very important if you don't do it. And learning, it doesn't have to be that detailed, but learning what everyone's doing and making sure that both process and possibly outcome measures are being monitored from the beginning and setting it up early so that you're not catching yourself behind the 8 ball or when people ask you to prove what you're doing is happening, number one, and is working. And there's a couple of programs that we use for that we can talk to you privately about if you had questions.
Yeah, I would just add one quick thing to that that tracking piece, that data management piece. When one of those programs that Joel is talking about, when we were in the process across the country of developing it, we enlisted the help of our violence prevention professionals because their notes and their data input is really the crux of it. They have, obviously the most time and effort placed with the clients themselves. So it's really important that they're part of the process of developing data management instruments and variables. So so we started looking, as mentioned earlier, recidivism is something that we understand has a lot of factors involved in it that have to do with ecology. And so we started to try to get at the heart of those social determinants of health and what we can do on an individual basis, ultimately to build social capital. And what we found that was really important in retaining someone in the program and having them not have emergency department visits for a variety of reasons was providing mental health services, culturally appropriate mental health services for our clients. So people in wraparound had a success rate that was much higher if we were able to meet those needs and meet in this case, we had many more adults than we had kids in the program. So meeting employment needs was really high. And then one of our violence prevention professionals calls what he does a dose as he's part of the trauma team. So we named it, we named it that based on Mike Texada's characterization. And if you had a higher dose or you spent more time with the violence prevention professional, that was seen as leading to a higher success rate. Really, our violence prevention professionals, as I mentioned earlier, are the backbone of our programs. Anything to add to that, Joel?
No, other than what can go wrong is you move a slide and then you get circles that don't match what you just did. So that should have been on the first slide.
Just really quickly, we've kind of gone over a lot of this before, so ignoring the needs of frontline workers, absolute error, and not picking up on the fact that they have absolute secondary trauma. We give them days off. If they just say, I need a day off, no questions asked. Not staying at the table, like Joel had said, having just one administrator calling that hospital buy-in. Now you have to really message it around the hospital with social workers, nurses, anybody who you think is going to come in contact with the clients. Excluding key partners, I think we've already covered as well. And then that 5-year plan that Joel talked about is really important, integral in providing security for your violence prevention professionals and the expectations that are coming from the communities that have been let down by the medical system in the past. And reporting in and of itself, which is so important for so many reasons, including characterizing where our barriers and pitfalls are, that can be a full-time job at times.
Yeah, and some of that reporting, some of us receive VOCA funding and other sources in Pennsylvania in particular, and the reports are really difficult to create and submit, and we constantly get messages that we didn't do it right. So we a person in our program is actually responsible for doing that, and it's not her full-time job, but it is a large part of her job. And so when you get the money, you have to actually think about writing that in so that you can give the money back in time of someone's thing. And it is true that grant expiration dates come up quickly, and thinking 2 years ahead, just like a foundation would, is really key. So we'll be able to stop for a few more questions. I'm not going to look at the chat, but Sherry is, just because if I do, I think you'll probably see that on my screen.
And there definitely, as always, comes up, there are funding questions, I think. And so Joel and I will be happy to talk about that.
The people on the screen, by the way, is Sandy Bloom, who's the queen of trauma-informed institutions, and Thea James from Boston in the middle there, two of our colleagues, and then John Rich up at the top there from Healing Hurt People.
Thank you. There are several questions here. Are there ways that an HVIP can handle info on possible future retaliation while respecting HIPAA and not being seen as part of law enforcement? I'm
thinking that Jody and Jackie would be best to answer that. I certainly am sitting in the clinical meetings and I know how that works. But we have something called the Tarasoff law or Tarasoff rule, which says that if someone is going to hurt someone else and they're a named assailant, we do need to report that. But that's in a medical community for sure. In general, we try and work with the client themselves, and if there's an issue of retaliation, safety is primary for our work. So we put safety planning, including retaliation issues, at the top of our list, and it's the first thing we manage. I'm going to let Jackie and Jody talk about some specific situations as to how to handle that. And we also, since we work with kids, we also have to worry about the kind of Department of Human Services and other issues with child abuse reporting. So that's something that I think they may be able to address as well. We don't work in the, again, violence interruption world, and so we don't actually work directly with police. We are with detectives for court cases.
Yeah, it's a great and can be a really complex question. The one quick thing that I will say about that is Wraparound is part of a network at the city of San Francisco that holds meetings every week with police, with violence interrupters, community-based organizations. There's a whole network that we formed about 15 years ago around this. And Wraparound is always asked, can you give information about this injury? And we're from the Department of Public Health, so we're part of you. We have HIPAA protection. We're part of this, but HIPAA is on a need to know basis. Just like I can't walk out over to the neurocritical care unit right now and just kind of check out somebody who had an aneurysm. Yeah, I have all the HIPAA stuff compliant, but unless I'm consulted, it's not my need to know basis. So the same thing holds for these programs, and it's really important to keep that at the table. And oftentimes the police will try to get information from violence prevention professionals, but it's what is necessary, what is needed is the crux of HIPAA, and we hold to that.
And the other thing I would mention is that these are questions that we struggle with right now. So that's an excellent question. this is something that the frontline workers work group would be talking about on their phone calls nationally, to get that kind of get everyone's perspective on how tied to the police would your program be seen and how negative or positive that can be. So thank you for that question. There's no right answer, which you can tell from our responses.
Will you be saying more about the involvement of mental health staff and
Yes.
add to that, their particular training towards the whole world of trauma and its aftermath?
Right. Well, I think that you'll definitely hear it in the next talk about how we've integrated into the CHOP program, but I think that UCSF and Wraparound has done an amazing job of integrating their work into mental health care. Partnerships are really important for that. And so, Rachel, I don't know if you want to talk about the partnership that you have at Wraparound.
Yeah, the Trauma Recovery Center in San Francisco was the original one, and I got involved in the development of Wraparound because they were having a hard time really enlisting mostly Black and Brown men in the program. They just were having a really hard time because they didn't have the cultural humility. So it became this amazing partnership where the violence prevention professionals from Wraparound went hand in hand with clients from our program to mental health services to create that bridge, and that still holds today. And we are part of the selection process, or rather, our frontline workers are part of the selection process of who our clients actually see in mental health services. That's been demonstrated to be a sustainable way of getting people to mental health services that they need and keeping them in mental health services.
Right.
So that partnership's been really
And vetting your mental health partners, using our violence prevention specialists to say they're really acting in a trauma informed or non-trauma informed way is important. So there are some partners that we choose not to work with because they just didn't treat our clients the way that we hoped. And when you find that good partnership, you have to, like we have one with Hall Mercer down in Philadelphia and others, and we actually are violence prevention specialists provide direct mental health care in trauma-focused CBT, which we'll talk about as part of the next talk.
Okay. Along with that, I heard you mention in terms of also being involved in transportation, like how do these individuals necessarily get to type of mental health professionals who are both trained and in culturally sensitive? Sometimes transportation is a barrier, and it sounds like that's part of the whole.
It is.
Uh,
It is, and thinking carefully about how many trains or buses someone has to take to get there, and even then, the extent to which our team gets people to mental health care is very high. 80% of our kids that need mental health care actually wind up having that goal met eventually, but sometimes it's a struggle and it takes a while to meet that goal because of the transportation.
and really sometimes the mental health services have to come to the client, and that's why we're able to set up an office for them once a week to come to Wraparound, because the hospital oftentimes in places is neutral territory and people can safely get there, but otherwise, other parts of the city not so much. So we worked out a system where the mental health provider came to the client, if you will.
And that's part of like listening to the clients and learning by trial and error what's going to work in your particular setting.
right.
Sure, I'm going to move on only because I'm worried. I
Yeah.
don't want to take up the next
Sounds good.
talks.
Sounds
Is that
good.
okay?
That sounds good.
So now the question is, how do we know it's working? Right. So this is kind of the researchy part of the talk. For those of you who have to go to the bathroom or don't, no, I'm just kidding. So what are the evidence of success? So the evidence of success in your own house is that you're too busy, right? You're getting known in your hospital, you're getting known in the community, and you're getting too many requests for your services, and you have capacity to provide, and probably should prepare for that and have kind of standard approaches to that. And then your clients are actually referring other clients, which doesn't necessarily work because our clients are all violently injured at this point. But the likelihood to use a service again is probably the highest satisfaction rating you can get. Nationally, we spend a lot of time trying to prove what we work. And Rochelle's going to go over some of the adult data, and I'll go some of the pediatric data. But there are really important logistical and ethical challenges to doing research in this arena, and which is why there aren't a ton of randomized controlled studies. in this field. I also think, and I will talk a little bit about spreading the word and hearing the word, and then finally, we're getting some government interest in this work, which has taken 2 decades to do. So move on to the kind of research evidence for HVIPs.
Yeah, so I can go really quickly through here, and this is just to demonstrate the rates of recidivism, so of re-injury, representation to medical care over time. And as Joel mentioned, there are ethical issues, like, for example, the IRB in San Francisco at UCSF didn't feel that they had the equipoise to say you can randomize. They wouldn't actually allow us to randomize as we started to talk about the possibility of doing it. They felt that something's got to be better than nothing, and it didn't look like there would be harm in doing a program like this. So we used historical controls in our work and found that there was a reduction in re-injury. But that said, it's important that there were, early on at least, there were some randomized controlled trials that made us feel like, okay, maybe we're onto something. But I still think that the future is along the lines of what Joel has done in a Delphi process, and he'll go through that to understand what our variables really need to be to really name success.
And I always like to say, in the pediatric world, the work is different, and a lot of all of this work is social work, right? Because it's social, it's important socially, but the ability to navigate systems for a family, and as Rochelle mentioned, taking on siblings and parents is really important. Now, this Tina Chang's work was actually a research program, wasn't and so we didn't count it as an HVIP in the world of what we just described, but she did look at a case management program and a mentoring program for youth. And you can see there was a slight, really, actually, this turned out to be no difference in the fight injuries of a mentoring program. But when they added case management to that program for assault injured youth, there was a very significant difference in at least the parental report of fight injury, and certainly in the youth report of fighting injury. So they were able to reduce it in this group that I believe was 8 years old and above that they did it in. And we always say, pediatric programs have a lot in common with adult programs or general programs, but there are some very significant differences as well. There's also a wonderful systematic review, England, on 10 studies, and I'll just read you the conclusions with that. They said it was the potential to produce significant reductions in arrests and re-victimization, which are really important, but also in these intermediate measures that are considered predictive. And those intermediate measures are often what we concentrate on as our outcomes, because we, especially in pediatrics, even though it's horrible when it happens, we don't have as much recidivism / return after injury to do the studies that would show for a particular program that it's reducing it. But we do change other outcomes that are known to lead to violence if they weren't mitigated. They also said that the combination of an ED-based intervention and long-term follow-up, you have to put your long-term follow-up in there, and that the teachable moment, as I mentioned before, has a half-life, so that getting to the patients early on, not necessarily the moment that they are injured, but soon after, is important. And then finally, trying again with someone. We know that we have gone back and forth with patients and clients, and we've had multiple contacts with them, and some of them they realize that we're there to stay. We're in their life, and they trust us more when there's multiple contacts than just one contact and then a referral, which we're not really considering an HVIP anyway.
Yeah, that's a really important point, Joel, just to hammer that down. I know a lot of our violence prevention professionals have said, look, his friends were in the room, so I'm going to go back later. Yeah, he said no to our services, but yeah, I'm going to go back later when his friends aren't there. And really having the clients understand that notion of, we're not going anywhere. That's really important.
In thinking about moving beyond re-injury outcomes, which is what a lot of grants had been asking us to look at, we're thinking about all these other outcomes that include the social determinants of health. And we undertook one study, and we're hopefully going to be writing a little bit more about this, where we actually asked stakeholders, which included with the directors of programs, but also frontline workers, what they thought they were changing in their clients and what was the most important to them. And the Delphi technique is a way of prioritizing those outcomes, and we came up with 17 main outcomes. Only the first 4 of them were around recidivism and reinjury, but the rest of them were mostly around mental health and quality of life. That those outcomes and that we thought we were changing and that we considered very, very important for future success. And so that was with 22 programs at the time, and now we have 44 programs possibly ripe for restudying it.
I just want to pause there and say that work that Joel spearheaded, it's essential. That is a Bible to have had that like set of variables that we need. So it was a huge contribution. And now at this point, it's really about spreading the word. And the American College of Surgeons, a couple of years ago, we had the opportunity to publish violence intervention programs, kind of the second primer, if you will, for developing a comprehensive program. And this goes through some of the pitfalls, and it goes through some of the sustainable actions that you can take to develop a program. So I would encourage you to take a look at that. It was done in 2017 now. It goes through some details, although the timeline is quite optimistic in it. And then developing a trauma-informed emergency department-based intervention for victims of urban violence from our friend Ted Corbin, Linda Rich, John Rich. So really important work. Back when we were an alphabet soup and an HVIP, the white paper that we put out that you can find on our website, on the Javi website, also goes through practices and policies to end the cycle of violence. And this field, as you could probably tell, is always actively evolving. We're looking forward to your contribution in it as part of our family and our network of programs. We learn from one another and have continued that spirit along the way.
And this is just a few of the items that have come out through the years. A lot of what we are trying to do is also spread the word through national media, either opinion pieces or speaking to reporters about this. The messaging is really important. I have to say, this year has gotten pretty heavy duty in terms of HVIPs and the government supporting them. And this slide is showing Fatima Dreyer, who's our executive director on CNN, talking about this. And we have had some inroads with the Biden administration and their plan to support violence prevention and include HVIPs in that funding.
As Joel was saying, it's just like it's an unbelievable moment in time that we're experiencing right now. We're seeing not only through the Economic Recovery Act funding coming through, earmarked as COVID-19 funds, but a lot of this can go towards community-based, which is hospital-based violence intervention programs. The American College of Surgeons Committee on Trauma has created their own mandate that they will engage in prioritizing hospital-based violence intervention and other violence intervention programming. And ultimately what we want to get to is that any hospital treating, say, for example, over 100 gunshot victims and other violence-related injuries per year, in those patients, those emergency departments and trauma centers should establish an HVIP. We are looking forward to Health and Human Services, Department of Justice, VOCA funding going towards this type of work. As Joel mentioned earlier in the talk, Medicaid, CMS has, as part of our taxonomy, the violence prevention professional. Now it's time for us to turn that dial and really start to have our violence prevention professionals be able to bill just like I would when I'm taking somebody to the operating room for the services that they provide. And there have been states such as Virginia and New Jersey who have made huge investments, millions of dollars investments. Most recently, Representative Ruppersberger and Kinzinger have a bipartisan Solutions for Cyclical Violence Act that just passed the House a couple days ago. So we'll see what happens. That was developed in conjunction with the Committee on Trauma and the Javi. We helped to write that bill, and we're hoping that funding goes through the Senate. It's millions of dollars for you to apply for hospital-based violence intervention programming.
And the Javi does have a policy work group and a policy director in Kyle Fisher, who is an emergency medicine physician from Maryland, who's done the yeoman's share of the work in trying to get these policies and laws passed in each state. And it is going to be state by state. I know Rochelle just mentioned the national spectrum, but every state can get the money, and then they have to decide how they're going to spend the money. And that's part of our goal, is to get them to understand the benefit of our programs. So in summary, I'm exhausted talking about this. And you're probably exhausted hearing about it, but the HVAPs are a lot of work, and they are hard to do, but they're worth it. There's so many programs that call themselves violence prevention programs. I'd rather call ours hospital-initiated violence prevention programs, not hospital-based, because we really only meet the patients there, but then they become clients in a community-based intervention. And but we're not going to change the term because everybody's using HVIPs, and HIIP is harder to say. We just want to say that Crozier and Chester Community Coalition, you're joining a wonderful club. As you can tell, we all love each other and work together and provide each other support. The evidence is there, but there's still so many roads that we have to take to build more. And the most important thing I can say is that Rochelle and I are the program directors, and we may sit on top of the bus, but our teams are driving that bus. And this is actually a picture of Rochelle from her younger days in California, sitting on top of the bus. So
I promise I'm not going to break into Valley Girl speak, Joel. It's just
thank
not
you
appropriate.
so much. I know we only have another, actually, we're kind of at our time.
Our national meeting, we have an annual meeting, and like last year, it's virtual this year. It's in the fall. We would love to have you join us just to check out and even virtually get a sense of what a family we are. So I hope you can tune into that.